I'm here today to present the results of a international randomized trial comparing two radiation fractionation schedules for men with intermediate risk prostate cancer. This is a trial that was sponsored by the Ontario Clinical Oncology Group and 27 centers in Canada, Australia, and France have participated, and we're quite excited to present our results here.
Could you tell us those results?
The purpose of the trial was to compare a 4-week course of radiation treatment to a standard 8-week course of radiation treatment. We hypothesized that the radiobiology of prostate cancer would allow us to compress the treatment into a much shorter treatment course. The concern there was that we would have more toxicity from the larger dose per fraction radiation. So we then used very conformal radiation treatment techniques to reduce the risk of toxicity. So the trial was commenced in 2005, and we now have a median 6 years of follow-up, a maximum of 10 years of follow-up. And we were very delighted to find that our experimental regimen was non-inferior to the standard regimen in terms of an endpoint that we called biochemical clinical failure. This endpoint is a compilation of PSA failure or clinical failure or death from any cause, whichever one happens first. And at 5 years, the BCF control rate was 79% for both treatment arms, and the survival curves did not diverge out to 10 years. And we were able to say that our short treatment arm was non-inferior to the standard treatment arm. More importantly, we did not see any increased toxicity with the short treatment arm. In fact, when we looked at grade 2 GI toxicity, there were fewer late grade 2, grade 3, and grade 4 events with the short treatment arm than the standard, so at least in terms of late GI toxicity, there appeared to be an advantage to the hypofractionation treatment arm. So we feel that we have demonstrated that a short course of 4 weeks of radiation should be the new standard for treating men with intermediate risk prostate cancer.
You mentioned the results from the numbers side. Have you got any feedback from the patients, how it's affected their quality of life?
It's a very good question. We looked at quality of life as part of the trial. It was one of our secondary endpoints. And in terms of the EPIC scores, the SF-12 scores, or the AUA toxicity scores, we did not see any difference between the two treatment arms. So unless we looked at baseline 24 months and 48 months. So at least for these time intervals, we did not see any disadvantage to hypofractionation, which is what we call short treatment course, for quality of life.
And imagine being able to get through the course much quicker and not have to make plans for 8 weeks, 8 months was...
8 weeks.
Yeah. Must be able to get a lot more done with your life.
And this was the whole point behind the study. Radiation takes a lot out of people's lives in coming to treatment each day, finding transport, taking time off work. And if we can have that, it is going to make their lives substantially easier. There's an added benefit, of course, in that we are essentially doubling the capacity of the healthcare system to provide treatment for these men.
And this was for intermediate risk prostate cancer. Are there any plans to branch out to other risk factors or to other tumors?
There has been another study done looking at low-risk prostate cancer that was very recently presented at a meeting last autumn, and it showed very similar results. So it does appear that by using modern radiotherapy techniques, we can compress treatment safely for prostate cancer. We are not certain whether the radiobiology works for high-risk prostate cancer, and these studies are ongoing and have to be demonstrated to adopt that. Everyone is interested in hypofractionation for very obvious reasons, and it has been examined in breast cancer and in lung cancer, and I imagine other disease sites as well.